Today, we are strapping in for a really detailed look at a system we all pretty much take for granted every single second. The peripheral motor system.
We really do.
I mean, just think about something as simple as grabbing a cup of coffee. The sheer complexity behind that simple act is staggering.
It is. Your brain sends the signal, sure, but the execution of that, it relies on this flawless, instantaneous communication across a really delicate three-part bridge.
Okay, so what's that bridge?
You've got the peripheral nerve, the wire, basically, then this highly specialized junction where the signal has to jump, and finally the muscle fibers that actually do the work and contract.
And that speed, that reliability.
Yeah.
It's incredible.
It's a precision machine, and when this whole system works, it's completely invisible. We just feel the result, the movement, but when even one tiny part of that chain fails.
And the results are profound. Weakness, sensory loss. And that's our mission for this deep dive. You've given us Chapter 27, Peripheral Nerves and Skeletal Muscles. And this is not a light overview. This is a deep textbook-level exploration of pathology and morphology.
Right. The goal today is a really thorough, grounded understanding. We're going to start with the fundamental anatomy, then get into the core ways things go wrong, what we call axonopathies versus demyelination.
And from there, we'll spend a lot of time on the specific diseases that affect each part of that chain, from the nerves all the way to the muscles.
And critically, we're going to translate the microscopic evidence. I mean, for you to really get it, you have to be able to visualize the disease process.
So we're talking about unpacking these complex diagrams.
Yes, and interpreting those pathology slides. We have to be able to recognize those essential hallmarks, things with names like trichrome stains, the famous onion bulbs, rimmed vacuolas, and the really striking ragged red fibers.
These are the visual signatures of disease.
They're the signatures that let us tell hundreds of different conditions apart.
That focus on the pathology is absolutely key.
Yeah.
So let's start with a broad definition. We're talking about neuromuscular disorders. What does that term cover? And maybe just as importantly, what does it exclude?
Right. So neuromuscular disorders, they usually present with things like weakness, maybe muscle pain or sensory problems. But the definition itself is purely anatomical.
Okay.
We're only concerned with conditions that affect the peripheral nerves, the neuromuscular junction, or the skeletal muscles themselves.
So what's excluded?
The central nervous system,
Yeah.
the CNS. We are explicitly leaving out disorders that start in the brain or the spinal cord. You can think of it this way. If the motor neuron in the spinal cord is the generator.
They were focused on the wiring and the motor it powers.
Precisely.
Okay, so let's start with the architecture of that wiring, the peripheral nerve system, or PNS. What is the precise chain of command in a single functional motor unit?
The motor unit is the essential pathway. It all starts with the command center, which is the lower motor neuron cell body that lives in the anterior horn of the spinal cord or sometimes in the brainstem.
And from there?
From there, the signal travels down this electrical cable we call the axon, and these can be incredibly long, running all the way down an arm or a leg.
And the final target?
The innervated muscle fibers. They get the signal and they contract. The health of that entire muscle depends completely on the health of that one neuron and its cable.
And these peripheral nerves, they're not just simple motor pathways, right? They're more like complex communication bundles.
Exactly. There are multifunction cables. We talk a lot about the somatic motor fibers, the ones going to skeletal muscle, but they also carry somatic sensory fibers.
Giving us our sense of touch, vibration.
And proprioception, knowing where your limbs are in space without looking. And very importantly, they also carry autonomic fibers.
The involuntary stuff.
The involuntary stuff. Regulating blood vessels, heart rate, gut motility. Damage to these autonomic fibers can be, it can be devastating, as we'll see when we get to something like diabetic neuropathy.
The thing that allows us to react instantly to catch that falling coffee cup is pure speed. And to talk about speed, we have to talk about myelin.
Myelin is the absolute key to velocity. In the peripheral nervous system, the Schwann cell is the master builder here. It wraps itself around the axon in this tight concentric spiral, forming a thick insulating sheath.
But the sheath isn't continuous. It has these little gaps.
Right, the nodes of Ranvier, and those nodes are where the magic happens. They turn nerve conduction from a slow crawl into an all-out sprint.
How so?
Instead of the electrical impulse having to travel smoothly along the whole membrane, that thick myelin insulation forces the signal to literally jump from one node of Ranvier to the next.
That's saltatory conduction.
That's saltatory conduction. It's incredibly fast and energy efficient, and it's used by the big, heavily myelinated fibers for quick movements. In contrast, you have these thin, unmyelinated fibers that just conduct slowly. They're usually carrying pain and temperature signals.
Let's zoom right into the microscopic level here, because the integrity of this myelin is often the first thing to go in disease. Figure 27.1 gives us this incredible close-up of the molecular structure.
It's a crucial diagram for understanding inherited neuropathies. It shows you how that Schwann cell membrane is so tightly compacted, and it highlights the proteins that act like structural glue, both inside and out.
So we have these layers of membrane pressed tightly together. What's the internal glue holding them?
That job falls mainly to a protein called myelin basic protein, or MBP. You can see in the diagram that it's an intracellular protein. It's inside the Schwann cell, and its whole function is to pull the inner faces of that membrane together to make the insulation dense.
So if MBP is faulty,
the whole myelin structure can just collapse.
And on the outside, there are these transmembrane proteins. And when they're mutated, it leads directly to some really devastating inherited neuropathies.
This is where it gets really interesting clinically. These proteins span the membrane and stabilize that outer surface. Figure 27.1 points out the key players: myelin protein 0, MPZ, peripheral myelin protein 22, PMP22, and a few others.
And a mutation in any one of these can cause disease.
Yes. A mutation in any of them can result in a structurally unstable myelin sheath. It leads to progressive demyelination, chronic dysfunction. For example, just having an extra copy of duplication of the PMP22 gene is the most common cause of Charcot-Marie-Tooth disease.
A single microscopic architectural flaw leads to a massive functional failure.
That's a perfect way to put it.
So moving from the single fiber to the whole nerve, it's not just a loose collection of axons, is it? It's a meticulously bundled cable.
Think of it exactly like a heavy-duty electrical cable. It needs layers of protection. The innermost, most delicate layer is the endoneurium that surrounds each individual nerve fiber, the axon, and its Schwann cell.
And then you bundle those individual wires together.
Correct. Those bundles of axons are called fascicles, and each fascicle is wrapped by the perineurium. Now, this layer is special. It's not just connective tissue, it's a vital barrier. It controls the microenvironment inside the nerve, protecting the axons from toxins.
And the final outer wrapping.
That's the epineurium. It's a dense, tough, connective tissue sheath that provides mechanical strength, holds all the fascicles together, and crucially, it houses the blood vessels that supply the nerve.
The vasa nervorum.
The vasa nervorum. Damage to that blood supply, as we'll see with diabetes, can spell disaster for everything inside.
So let's talk about disaster. What happens when a nerve is severely traumatized or even cut cleanly? The body's response is a process called Wallerian degeneration.
Wallerian degeneration is this organized and frankly quite dramatic self-destruction of the nerve segment that's been cut off from the cell body.
So the distal part just dies.
It does. It can't survive without the nutrients and proteins from the cell body, so the axon quickly fragments and the myelin sheath just breaks up right along with it.
And this creates a lot of debris that needs to be cleaned up.
A huge amount, and that's where the macrophages come in. They are the cleanup crew. They rush in and strip away all the degenerating myelin and axon debris. But the key to any potential recovery lies with the surviving Schwann cells.
What do they do?
Even without the axon, they remain, and they form these longitudinal columns, sometimes called a Schwann cell tube.
So they basically create guide rails for any potential regrowth.
That's exactly what they do. Regeneration is possible, but it's slow, painfully slow. New axonal sprouts grow along those Schwann cell columns at a rate of roughly 1 millimeter per day.
Wow, that's incredibly slow.
It is. And if the axon successfully finds its way back to its original target, a muscle or a sensory receptor function can be restored.
Right.
But if it gets lost,
What happens then?
if the outgrowth is disorganized or it misses its target, you get this tangled mess of nerve endings and Schwann cells. It forms a painful, palpable mass we call a pseudotumor or a traumatic neuroma.
Basically a nerve ending that got lost and balled up on itself.
Precisely. It's the physical evidence of a failed regenerative journey.
This anatomy brings us to a really core diagnostic distinction in all of peripheral neurology. We have to look closely at figure 27.2, which shows the patterns of peripheral nerve damage. Getting this difference, axonopathy versus demyelination, is the first step to any diagnosis.
This contrast is the entire ballgame. The figure shows the normal state and then the two primary ways a nerve can fail.
Let's start with 27.2a, the normal motor unit. Remind us what a healthy muscle looks like in cross-section.
In a healthy muscle, you have to see that mixed, alternating checkerboard distribution of type I and type 2 fibers. The axon itself should be uniform, with healthy, thick myelin segments.
Okay, now to figure 27.2b. Axonal neuropathy or axonopathies. This is damage to the wire itself.
Right. In an axonopathy, the primary problem, often a toxin or a metabolic issue, kills the axon. The myelin sheath then degenerates secondarily because its health depends on the axon.
This is the dying back pattern we hear about.
Often, yes. The longest axons, the ones going to your feet, are affected first. In the diagram, you can see the right axon is just breaking down, fragmenting.
And the muscle fibers connected to that dead axon.
They lose their signal, their support, and they immediately start to atrophy. So in a biopsy, you'd start to see these clusters of small, sunken muscle fibers.
So if you cut the wire, the electrical signal just stops. What does that look like electrophysiologically?
Well, since the number of conducting cables is reduced, the total signal that gets through to the muscle is much weaker. So the hallmark is a reduced amplitude of the compound muscle action potential, or CMA. The speed of the signal might be normal in the surviving nerves, but the overall volume is low.
Now let's contrast that completely with figure 27.2c, demyelinating neuropathy. Here, the wire is fine, but the insulation is damaged.
Exactly. This is often an immune attack, like in Guillain-Barré. The target is the Schwann cell, or the myelin sheath itself. The axon is usually spared, but the insulation gets stripped away in random patches. We call that segmental demyelination.
And this forces the signal to slow right down, because it can't do that jumping thing anymore.
Precisely. The current leaks, the signal slows to a crawl. The body tries to repair this, but the new myelin segments it creates are characteristically shorter and thinner than the original ones.
So if the wire is still there, the strength or the amplitude should be okay, but the speed must be shot.
That is the core takeaway. The electrophysiological hallmark of a primary demyelinating neuropathy is slowed nerve conduction velocity. Low amplitude means axon loss. Slow velocity means myelin loss. That distinction guides everything that follows.
That's incredibly clear. Before we get into specific diseases, let's just quickly frame this with the anatomical classifications. Where the damage happens and how widespread it is dictates the clinical pattern.
These are essential for localizing the problem.
The simplest pattern is mononeuropathy.
That's damage to a single nerve, usually from trauma or entrapment. Carpal tunnel syndrome is the classic example. The symptoms are confined just to that one nerve's territory.
What if several different nerves get hit, but in a random pattern?
That's mononeuropathy multiplex. It looks like several separate individual nerve injuries happening at once. This pattern is a huge red flag for a systemic cause, like vasculitis, where inflammation is randomly knocking out the blood supply to different nerves.
And the most common pattern?
That would be polyneuropathy, specifically distal symmetric polyneuropathy. It affects many nerves symmetrically. And because the longest nerves are the most vulnerable, symptoms almost always start in the feet and move up, creating that classic stocking and glove pattern of sensory loss.
Diabetes being the textbook cause.
The absolute textbook cause.
And finally, polyradiculoneuropathy.
The radiculo part means it involves the nerve roots, right where they exit the spine. So the symptoms are diffuse and symmetric, but they often involve proximal muscles, the hips and shoulders, just as much as the distal ones. Guillain-Barré is a classic example.
Okay, with that foundation built, we can start applying it. Let's move from the mechanisms to the specific diseases, starting with the classic acute demyelinating disaster, Guillain-Barré syndrome, or GBS.
GBS is defined as an acute inflammatory demyelinating polyradiculoneuropathy. It's an autoimmune, life-threatening condition that needs immediate recognition.
What does the clinical picture look like?
It's a rapidly evolving, usually ascending weakness. It often starts in the legs and just moves up the body over days. Patients lose their deep tendon reflexes, and the hallmark is the speed. Symptoms usually peak within about 4 weeks.
And the cause is often this post-infectious trigger, right? Molecular mimicry.
Exactly. In about 2/3 of cases, GBS follows an acute infection. The most famous one is a gut bacteria called Campylobacter jejuni, but viruses can do it too. The body creates antibodies to fight the bug, but those antibodies get confused and cross-react with antigens on our own peripheral nerves.
So it's a case of mistaken identity leading to immune cells stripping the insulation off the nerves.
It's a full-on cellular assault. T cells get it started, but then macrophages become the main destructive force. They literally infiltrate the nerve and strip the myelin sheath right off the axon.
Let's talk about the pathology. The discussion of demyelinating disease always brings up the onion bulb structure from figure 27.5. Do we see that in GBS?
That's a great question and an important nuance. Onion bulbs are actually less common in acute GDS. They are the definitive hallmark of chronic demyelinating neuropathies, where there's been damage and repair over and over again for a long time.
So the onion bulb represents the body's long-term, imperfect attempt at repair.
Precisely. Figure 27.5 shows this striking image of concentric layers of Schwann cell processes and basement membrane all wrapping around a central axon. They form because the nerve is constantly going through cycles of demyelination and remyelination. Each repair attempt adds another layer, like rings on a tree or layers of an onion.
And the clinical course for GBS is very serious.
It is. Most patients recover, but about 20% are left with some disability, and the mortality rate is still 2 to 5%, usually from respiratory failure or autonomic problems.
Now, how does that compare to chronic inflammatory demyelinating polyradicular neuropathy, or CIDP?
CIDP is essentially the chronic twin of GBS. The underlying mechanism is similar, but the disease course is persistent, lasting 2 months or more, often with relapses and remissions.
So in a biopsy of CIDP, you'd be much more likely to see those onion bulbs.
Far more likely because the chronic, relapsing nature of the disease gives them time to form. And because it's chronic, the treatment approach is a bit different. It responds well to long-term immunosuppressive drugs, like corticosteroids.
Okay, let's shift gears to neuropathies that come from major systemic diseases, starting with the absolute giant in this field, diabetes mellitus.
It's the most common cause of peripheral neuropathy in the world. The numbers are staggering. Up to half of all people with long-standing diabetes will develop some form of it.
What's the underlying pathology? It feels like it's both a metabolic problem and a vascular one.
That's a great way to summarize the complexity. The chronic high blood sugar directly harms the nerve cells and Schwann cells. It creates metabolic stress and reactive oxygen species. But just as important is the associated microvascular disease.
And we can see that in figure 27.6. What tells us the blood supply is compromised?
The figure points out the severe damage to the small blood vessels supplying the nerve, the vasa nervorum. You see this dramatic thickening and hyalinization of the basement membranes in the arterioles.
So the pipes are getting clogged.
The pipes are getting clogged and stiff. This restricts blood flow, starving the nerve fibers of oxygen and nutrients, which contributes to both axonal degeneration and demyelination.
And this combination leads to that classic stocking and glove pattern.
Yes, but the impact of the autonomic neuropathy and diabetes is something we have to stress. This is damage to the small, unmyelinated fibers.
Give us an example of how damaging that can be.
It can be life-threatening. Patients can get orthostatic hypotension where they faint when they stand up. They can have severe gut problems. And critically, it can mask the warning signs of a heart attack by damaging the nerves that carry cardiac pain. They can have what we call a silent heart attack.
Wow. Now, another vascular cause is vasculitis.
Vasculitis is direct inflammation of the blood vessel walls. When it hits the vessel supplying a nerve, you get focal areas of ischemia, basically tiny strokes within the nerve tissue.
And that's what causes the mononeuritis multiplex pattern.
Exactly. Because the attacks are random and patchy, you get that hallmark haphazard pattern of damage, hitting one nerve here, another nerve there. It should always make you think of a systemic autoimmune disease.
Next up, toxic neuropathies. These are caused by substances that directly attack the axon.
The list is long. Industrial toxins like lead and arsenic, but clinically we see it most often from therapeutic drugs. Many common chemotherapy agents are potent neurotoxins that cause that dying back axonopathy.
And finally, infectious neuropathies. Let's start with leprosy.
Leprosy is fascinating because it's temperature dependent. The bacterium, Mycobacterium leprae, prefers cooler temperatures, so it selectively infects Schwann cells in the distal parts of the body, the ears, hands, and feet.
And the inflammation damages the nerves.
It causes segmental demyelination and a profound loss of sensation, especially pain and temperature. And that sensory loss is what's so devastating because patients can't feel minor injuries, which then lead to chronic ulcers and infections.
What about shingles?
Shingles is the reactivation of the chickenpox virus, which lies dormant in the sensory neurons of the dorsal root ganglia. When it reactivates, it causes a painful sensory neuropathy in a very specific band-like pattern, a dermatome, followed by that classic rash.
Let's close this nerve section with the most common inherited neuropathy. Charcot-Marie-Tooth disease, or CMT.
CMT is a huge group of disorders, genetically very diverse. Clinically, it's a progressive distal weakness and sensory loss, often leading to foot deformities. We split them into type 1, which is demyelinating, and type 2, which is axonal.
And this brings us right back to figure 27.1 and that PMP22 protein.
That's right. The most common form, CMT1A, is caused by a duplication of the gene for PMP22. This overproduction messes up the formation of the myelin sheath. Pathologically, over decades, this leads to extensive segmental demyelination and the formation of those classic onion bulb structures we talked about.
It's a perfect example of a genetic architecture failure.
It really is.
Okay, we've navigated the nerve. Now we move to the next stop on the chain, the neuromuscular junction, or NMJ. This is where the electrical signal gets converted into a chemical one.
The NMJ is an incredible synapse. The motor axon terminal releases vesicles full of the neurotransmitter acetylcholine, or HE. It crosses the synaptic cleft and binds to achy receptors on the muscle side, which triggers the contraction.
So if the problem is at the junction, how does that present differently than a nerve or muscle problem?
Disorders of the NMJ have a very specific signature: fluctuating muscle weakness and profound activity-dependent fatigability. And critically, since sensory nerves bypass the NMJ entirely, these disorders almost never have sensory deficits.
So no numbness or tingling. That's a big clue.
A huge clue.
The classic example is myasthenia gravis, or MG. This is an autoimmune attack on the postsynaptic side.
MG is caused by autoantibodies that attack the acetylcholine receptors themselves.
What do these antibodies do to the receptors?
They attack them in three ways. They physically block AC from binding, they cause the receptors to be degraded faster, and they activate the complement system, which just destroys the membrane. The end result is you just don't have enough working receptors to get a reliable signal through.
And there's a strong connection to the thymus gland.
Very strong. About 65% of patients have an enlarged thymus, and another 10 to 15% have a tumor of the thymus, a thymoma. We think the thymus is where this faulty immune response gets started.
Clinically, where does this weakness show up first?
It has a classic pattern. It hits the small, frequently used muscles first, so the eye muscles leading to eyelid droop, which is ptosis, and double vision diplopia. It can also affect the bulbar muscles, making swallowing and speaking difficult, especially at the end of the day.
Treatment involves boosting the signal and suppressing the immune system.
Right. We can use anticholinesterase inhibitors to keep more acetylcholine hanging around in the synapse longer, but the definitive treatments are immunosuppression, or things like plasma exchange to remove the antibodies. And often, removing the thymus can induce remission.
Now, the crucial differential diagnosis for MG is Lambert-Eaton myasthenic syndrome, or LEMS. Also autoimmune, but it attacks the presynaptic side.
LEMS is fundamentally different. The antibodies here block the presynaptic voltage-gated calcium channels. Calcium rushing in is the trigger for the nerve to release acetylcholine. If you block that, you don't get AC release.
How does that change the clinical picture compared to MG?
The key differentiator is that in LEMS, strength often temporarily improves with repeated exercise. A rapid series of stimulations can force enough calcium in to overcome the block for a moment. This is the exact opposite of MG, where weakness gets worse with repetition.
And the cancer association is extremely high.
It is. LEMS is a classic paraneoplastic syndrome. About half of all cases are associated with an underlying cancer, almost always small cell carcinoma of the lung.
Fascinating. And of course, the NMJ is also vulnerable to toxins.
Absolutely. The most famous is botulism. The botulinum toxin, Botox, is incredibly potent because it specifically blocks the release of acetylcholine from the presynaptic terminal, causing paralysis.
And the plant toxin Curare.
Curare works on the other side. It
Yeah.
blocks the postsynaptic acetylcholine receptors, physically preventing AI from binding. It basically does the same thing as the MG antibodies, but from an external source.
Okay, we've covered the nerve and the junction. The final stop is the muscle itself. We're now in the realm of myopathies.
These are diseases where the problem is intrinsic to the muscle fiber. And the good news is that muscle, unlike the brain, has a real capacity for repair.
Through satellite cells.
Correct. When a fiber gets damaged, these precursor cells, called satellite cells, get activated. They can multiply and fuse to form new fibers as long as the nerve supply is intact.
Now we come back to what you said was the most critical diagnostic point of this whole deep dive: differentiating nerve damage from muscle damage. We have to really break down figure 27.7, neurogenic versus myopathic atrophy.
This is the primary reason to do a muscle biopsy. The pattern of atrophy tells you everything.
Let's start with 27.7a, normal muscle. We see that mixed checkerboard again.
Right, that random intermixing of fiber types is the sign of a healthy, well-innervated muscle.
Okay, now to 27.7b and c, neurogenic atrophy. This is caused by the death of the motor neuron.
When a motor neuron dies, all the hundreds of fibers it was supplying are suddenly cut off. And this results in a very specific pattern: large clusters of small, atrophied fibers all grouped together. This pattern screams loss of an entire motor unit.
And the surviving neurons try to compensate, which leads to another key sign, fiber type grouping in figure 27.7.
This is definitive proof of a chronic neurogenic process. A nearby healthy motor neuron will sprout a new axon branch and reinnervate those orphan fibers. But when it does, all those fibers change to match the fiber type of their new parent neuron.
So you lose the checkerboard.
You lose the checkerboard and you get these big, unnatural blocks of all one fiber type. It's a dead giveaway for chronic denervation and reinnervation.
Now contrast that with 27.7D and E myopathic changes. Here, the damage is inside the muscle cell.
In a myopathy, the damage is random and fiber-specific. You might see one dead necrotic fiber right next to a completely healthy one. The atrophy is individualized. You'll see things like regeneration and inflammation, but the overall checkerboard pattern of the surviving fibers is still there.
That distinction is so clear. Let's look at the main inflammatory myopathies, which are immune-mediated attacks on the muscle.
Right. You have dermatomyositis, which hits the skin and the muscle. Pathologically, it involves inflammation of the small blood vessels, which leads to this characteristic atrophy around the edges of the muscle fascicles.
Then polymyositis, which is a direct T-cell attack on the fibers.
Yes, T-cell-mediated destruction, usually causing proximal weakness.
And then there's the really interesting one, inclusion body myositis, or IBM.
IBM is different. It's the most common inflammatory myopathy in people over 50. It progresses slowly, and the pathology is what really sets it apart.
And that pathology is in figure 27.9, the rimmed vacuoles. What are we looking for in a biopsy?
On a special stain called a Gamori trachrome, you look for these little holes, or vacuoles, inside the muscle fiber. And what makes them unique is a surrounding rim that stains reddish granular.
Rimmed vacuoles. And what's in those rims?
This is where it gets fascinating. The rims contain aggregates of proteins that we normally associate with neurodegenerative diseases, like beta-amyloid and TDP-43. It suggests that IBM has both an inflammatory component and a degenerative one.
Let's turn to the inherited muscle diseases, the muscular dystrophies. We have to start with the most severe. Duchenne muscular dystrophy, or DMD.
DMD is a devastating X-linked disorder that affects young boys. Onset is early, around 3 to 5 years, with rapid progression.
And the core problem is a protein called dystrophin. Let's use figure 27.10 to explain its crucial mechanical role.
Dystrophin is the muscle's internal shock absorber. As you can see in the diagram, it's this huge protein that connects the internal cytoskeleton of the muscle fiber to the cell membrane, and then through a whole complex of other proteins, it links out to the extracellular matrix.
So it provides stability during the massive stress of muscle contraction.
Exactly. And in DMD, the genetic mutation leads to the near-total absence of functional dystrophin. Without that mechanical link, the cell membrane is incredibly fragile. Every contraction causes microscopic tears, which lets a flood of calcium rush in, and that calcium influx kills the muscle cell.
This process is captured in the histology of figure 27.11.
It is. Initially, you see a lot of variation in fiber size with ongoing necrosis and regeneration, but over time, the damage overwhelms the muscle's ability to repair itself. And the most striking thing you see is the massive replacement of muscle tissue by fibrosis scar tissue and fat. The muscle is literally replaced by scar and grease.
And the definitive proof is the immunohistochemistry in figure 27.11c.
Right. A normal muscle fiber stained for dystrophin shows this nice, continuous rim around the membrane. In DMD, as you can see in the figure, there's a complete absence of that stain. That total loss confirms Duchenne and separates it from the milder form, Becker muscular dystrophy, where you still have some partially functional dystrophin.
Shifting to myotonic dystrophy, which is famous for that sustained muscle contraction.
Myotonia, that inability to relax the muscle quickly. It's the most common adult-onset dystrophy.
Clinically, is that why patients report not being able to let go after a handshake?
That is the classic clinical sign. The pathogenesis is really interesting. It's caused by an expansion of CTG triplet repeats in a gene. This abnormal RNA becomes toxic and interferes with the splicing of many other genes, including a crucial chloride channel that is responsible for muscle relaxation.
So a faulty chloride channel leads directly to myotonia.
Directly.
Next, let's look at when the muscle's power plant fails. Mitochondrial myopathies.
These are from defects in either mitochondrial or nuclear DNA that impair the ability to make ATP, the cell's energy currency. So tissues with high energy demand, muscle, brain, heart, suffer the most.
And the pathology here is so unique. The diagnosis hinges on finding ragged red fibers in figure 27.7.
Yes. On that Gamori trichome stain again, the affected fibers appear red, granular, and irregular, with these aggregates of abnormal mitochondria bunching up just under the cell membrane. They look ragged.
And if you zoom in with an electron microscope,
You see these massive buildups of structurally abnormal mitochondria. They often contain these unique crystalline structures nicknamed parking lot inclusions because of how they're arranged. Finding ragged red fibers is the key to diagnosing these complex syndromes.
okay, we're in the home stretch. Our final deep dive segment is on tumors of the nerve supporting structure, peripheral nerve sheath tumors.
Most of these are benign and come from Schwann cells or fibroblasts. We classify them as schwannomas, neurofibromas, and the malignant ones, MPNSTs, and we often see them in the context of inherited syndromes like neurofibromatosis.
Let's start with schwannomas. What makes them surgically favorable?
They are benign tumors made only of Schwann cells, and they are encapsulated. They tend to push the nerve aside rather than grow through it. This encapsulation is key because it often allows a surgeon to dissect the tumor away without sacrificing the nerve.
And microscopically, they have a very specific biphasic pattern.
They do. They have a mix of Antoni A and Antoni B areas. Antoni A areas are very cellular, with this feature called nuclear palisading, where the nuclei line up in rows. In between these rows, you can get these acellular zones called Verrocchi bodies.
And Antoni B is the contrast to that.
Antoni B is the loose, less cellular, more myxoid area.
In stark contrast to the clean encapsulation of schwannomas, neurofibromas are integrated right into the nerve.
That is the critical difference. Neurofibromas are not encapsulated. They're a mix of Schwann cells, fibroblasts, and other cells, and they grow within the nerve fascicles, making them much harder to remove without damaging the nerve.
Let's focus on the most clinically significant type, the plexiform neurofibroma, from figure 27.14.
The plexiform neurofibroma is almost pathognomonic for neurofibromatosis type 1. It grows along multiple nerve fascicles at once, creating this palpable, ropey thickening that clinicians famously describe as feeling like a bag of worms.
Microscopically.
The cells are set in this loose myxoid background in these wavy bundles that have been likened to shredded carrot. But the significance is that, unlike other neurofibromas, the plexiform type carries a serious 5 to 10% lifetime risk of malignant transformation.
Which brings us to the malignant peripheral nerve sheath tumors, or MPNSTs.
These are highly aggressive, high-grade tumors, and the crucial fact is that about half of all MPNSTs arise in patients with NF1, usually from a pre-existing plexiform neurofibroma that turned malignant.
So let's define the two big inherited syndromes that drive these tumors.
Neurofibromatosis type 1, NF1, is the more common one. It's a multi-system disorder with skin findings like cafe au lait spots and a high risk for neurofibromas and MPNSTs. The gene encodes neurofibromin, which is a tumor suppressor that acts as a brake on the RAS pathway. Lose the brake, and you get uncontrolled growth. And NF2.
NF2 is less common, but is classically defined by the development of bilateral eighth nerve schwannomas. These vestibular schwannomas lead to hearing loss and balance problems. The gene here encodes a different tumor suppressor called Merlin.
So we have completed this exhaustive tour of the peripheral motor unit, hitting all three failure points: the nerve, the junction, and the muscle.
We really have.
Okay.
And we established that fundamental diagnostic vocabulary, the difference between primary loss of the conductor or axonopathy, which gives you low signal amplitude.
And primary loss of the insulation or demyelinating neuropathy, which gives you that slowed conduction velocity.
And we translated that visual pathology, the onion bulbs of chronic repair, the replacement of muscle by fat and scar in Duchenne, the inflammatory and degenerative signs in inclusion body myositis.
And the energy failure shown by those ragged red fibers.
It's all about localization. Understanding that failure point is the difference between prescribing immunosuppressants for GBS and pursuing gene therapy for DMD. The distinction between neurogenic atrophy with those big clusters of small fibers and myopathic atrophy with its random individualized fiber damage really is the intellectual scaffolding for all of this.
It absolutely is.
As we wrap this up, the sheer elegance of this system is just breathtaking. But we've seen how tiny single protein defects can completely shatter it, which makes me wonder, considering the hundreds of proteins needed to keep this system perfect and all the genetic variability we have, how much biological redundancy, how many internal backup systems does our peripheral neuromuscular system actually possess, and what pathways, beyond just replacing the broken part, might we eventually be able to harness to exploit that resilience and achieve real long-term recovery?
That is a fantastic question, and one worth continuing to explore.